Okay. Good evening, everybody, and good evening to the respected dignitaries on the dais. Dr. Krishna Kumar, I've just changed this a little bit after discussion with Rajesh Sharma, because funding of pediatric cardiac surgery and cardiology is the aspect of global health financing. So we will sort of discuss it with respect to that and various models which are there across the different countries. So if you look at financing, of congenital cardiac surgery and cardiology services, or any healthcare financing globally, we come to actually 4 different models, or what we would call philosophies. So the first model is what is called as the Beveridge model. And this is the model which is brought by some Mr. Beveridge from UK. And it is the model from which the National Health Service came into being after 1948. So the basic tenets of this model are the healthcare should be universal. As far as possible, there has to be a single provider. At a point of care, the healthcare should be free. And then you'll have to finance that healthcare. Now, this type of model is now being followed in the UK, Italy, Spain, Denmark, Sweden, Norway, and New Zealand. The second model is the Bismarck model, and not surprisingly, it comes from Germany, and it is more of a socialistic model, or it is also called as the social healthcare model, wherein the healthcare system is substantiated by social insurance, and the social insurance is non-competitive, and the private players are not a party to that social insurance. It is a no profit, no loss kind of healthcare model. And this model also is providing universal coverage and also has a single source, mainly for deployment of healthcare. And the Bismarck model is being followed in Germany, France, Belgium, and Japan, and to a certain extent in Latin America. The third model is the national insurance model. And this model is mainly insurance-based, but here, unlike the Bismarck model and the Beveridge model, though it provides a universal healthcare and it is sourced to a single source, there are private insurers which put in addition to the social insurance kind of schemes. So it becomes a bit competitive, but ultimately there is a common pool, and this model has got a huge amount of buying power. And this is the model they are following in Canada and at the moment in Taiwan and South Korea. And this seems to be working very well. The fourth model is the out-of-pocket model. And in the developed world, we have got organized system of providing healthcare services, but most of the countries are not that organized, and most of the nations on the planet are too poor or too disorganized to provide a systematic healthcare service to the population they serve. So in those countries, the access to the healthcare, because of lack of governmental support or lack of insurance systems or lack of private players, quite a substantial amount of patient population is going to pay for their own healthcare. And this is the case in 2/3 of the world at the moment. There is also what is called as a combination model, which I think is similar between India and the US. And I'm quoting verbatim this from the Association of Physicians of the US, that any American will understand these 4 models because they have got components of all the 4 models here. So when they are treating the veterans, it is universal and it behaves like Britain or Cuba. If Americans are over 65 with Medicare, it behaves like Canada. For working Americans who have got insurance on the job, it behaves like Germany. And for those 15% who have none of the above, it behaves like Cambodia, rural India, or Burkina Faso. So India also has got more or less similar, except that the percentages are a bit different. And I'll show you the graphs to show that. So these are the 4 basic models, or 5 basic models on which healthcare is funded. Now, what are the funding schemes? And there are a lot of funding schemes. There are government schemes where the government pays into healthcare. There is social health insurance. There is compulsory private insurance. There is compulsory medical saving account, voluntary health insurance, a lot of non-profit organizations which are donation-based. There are a lot of corporates who are involved in CSR, out-of-pocket spending, and then there is foreign aids where countries help each other. So let me skip this. So when actually you look at it, so if you look at United Kingdom, where is the money coming from? So most of the healthcare is funded by taxation. If you look at Denmark, it is a decentralized system where the taxes are local as compared to national, and the regions are allowed to take care of their own healthcare system. In France, it is more like a social system where the employer and employee pay into the insurance system to pay for their healthcare. Now, Singapore is a very good model and it is performing very well for quite some time. And what they have got is a catastrophic health insurance, and there is tax exemption on health saving accounts. So they have got a compulsory health saving account. They have insurance for catastrophes, and the government provides incentive to do that. Similarly, Switzerland, which also has got a compulsory social health insurance for everybody who is employed. So all the models have different ways of different sort of proportions of governmental spending, insurance spending, voluntary spending, etc. But when you look at the world in general, the amount of spending per capita is very variegated. Different countries spend differently on healthcare, and you can see it can be as less as $50 per capita to up to $2,000 per capita, and that is seen in the world map in the WHO site. So what we sort of, when you analyze this a bit better, we will see that the high income countries spend quite a substantial amount of GDP into health, and it goes up to 9 for the US, UK, and 29 high income countries. And for the low and middle income countries, it falls to less than 5. So though the global spending has doubled in the past 2 decades, and it is amounting to $8.5 trillion in 2019, and it is 9.8% of global GDP, 80% of it is located in the highly developed countries. Health spending is low in low-income countries. In the high-income countries, government takes up more than 70% of the cost of the healthcare. It has increased in the past 2 decades from 2000 to 2020. The low-income countries depend either on out-of-pocket expenditure, or they are depending on external aid. So this is a typical graph of a spending in a high-income country. So the blue bars is the spending by the government, which comes to about 70% on an average. The light blue is social insurance, and the one in the middle is the out-of-pocket spending in the 29 high-income countries as designated by WHO. So among these 29 highly developed countries, actually the spending has doubled from 2,000 odd US dollars to about almost $5,000, and the GDP has risen from 7 to 9% as far as healthcare spending is concerned. These healthcare models have been stable, and despite the global financial crisis in 2007 and 8, they have remained stable, and these countries were able to provide a safe, sustainable healthcare to most of their citizens. These are just some graphs which I wanted to show about the disparity in spending in most of the countries and how they differ. So we have got these 2 countries which are in the top 10 of quality of care as determined by the WHO. So on the left side is the United Kingdom, and down below is Sweden. In both these countries, almost 80% of the healthcare is provided by the government. If you look at Sweden, then there is no social insurance scheme, and about 10 to 15% of its spending is out of pocket, basically. And these 2 countries have got a exceptionally good healthcare system, which is stable. I know there is some crisis in the NHS at the moment. So Qureshi, I've been a part of the NHS. So I know the faults of the model, but yes, but despite that, it is more or less universal. There are long waiting times, and there are disadvantages of the model as well. But it is a universal model, basically. Now, if you look to Switzerland, Israel, these are the 2 countries where the government spending is not as much as the United Kingdom or that of Sweden. It falls to about almost about 40%. But these countries have a very robust social insurance schemes which compensate for the deficit of the government. So you will see a substantial amount being provided by the social insurances. The out-of-pocket expenditure also is about 15 to 20%, and there are schemes for voluntary insurances. These are also 2 countries which are considered to have a very good and robust healthcare system, and Switzerland also falls in the top 10 in terms of quality. look at the countries which become to the low middle or the low income group. And I've taken these two countries, Haiti and Rwanda. So you will see that the government spending, the blue bars in both these countries are very small. So the government spending in these countries is relatively low. Both these countries rely heavily on external aid, which are the green bars in the middle, you can see. And you will see that the social insurance systems in Rwanda are increasing slightly, but Haiti still falls behind. So if you take away the aid from these countries, then the citizens of these countries are going to suffer dramatically. We come to Afghanistan, and the other country is Yemen. Now, these are the two countries where, again, healthcare spending by the government is relatively low. More than 60 to 70% of the healthcare spending is out of pocket and provided, and people have to buy it on their own. If they do not have the money, there is no aid. So these are the countries which do not have aid, which do not have government spending. So if you have enough money, you will be able to buy health. And lastly, I compare these two models. One is India and the other is US. So in India, the government spending on healthcare is around 30 to 40%. Most of the healthcare is taken care of by out-of-pocket expenses. There is, the yellow bars are some voluntary insurance schemes, and the purple bars are other sources of expenditure, which means foreign aid, donation, CSR, etc. Now, US, if you look at it, the government spending is slightly better as compared to India. There is a robust insurance scheme, but it does not contribute that much. Out-of-pocket expenditure for the patient is far more less as compared to India. But in the recent years, since 2015, in the US, the voluntary insurance have actually dried down, and other sources of healthcare system has increased, and that is seen in the purple bars. So they, at the moment, in the past 4 or 5 years, are realizing, apart from the insurance system, apart from the government spending, they are sort of relying on other sources of income to fund their healthcare system. So if you just want to sort of summarize this, we have low and middle income countries who have to spend heavily out of pocket. We have the high middle and high income countries where there is a substantial amount of healthcare provision by the government and the social insurance schemes. But there is a very healthy trend which is going on in the last 15 to 20 years, wherein the out-of-pocket spending across all 4 groups is diminishing in all the 4 groups. So the WHO has classified countries into 4 groups, into low income groups, low middle income groups, upper middle income groups, and the high income groups. And if you look at graphs on all the sides, the red bar seems to be diminishing, and we hope that the bar continues to go on diminishing, and we find more and more sort of avenues to help our patients. So why do this healthcare system work? So one thing is, in high income countries, health is a priority. So they actually give a lot of their GDP to health. And if you compare that with low income countries, it consistently falls below 5% of their GDP, and some countries as low as 1 or 2. So if you look at the comparative allocation at the national and international level, in the 29 high-income countries, you see the blue bar is the amount the government spends in health. The orange bar is the amount which the government spends on education. The red bar is the amount the government spends on defense, and the green is on environment. So you can see almost 80% of the budget of the 29 high-income countries goes into education and health, and lastly, environment. And the defense, I think, falls maybe 3rd or 4th. Now, if you spend a lot on healthcare, does it automatically translate into quality? Maybe not. Just because you pour in money, the money has also to be utilized without wastage and without efficacy, with efficacy actually, and you also have to consider cost effectivity. So you see this graph where the top 11 countries it's a league table of countries based on the quality of care they provide. And then so Qureshi would be happy. UK is first. So in terms of effective care, safety, coordinated care, patient-centered care, and then they are categorized. And at the bottom, if you can see, it's the amount of spending per capita. So US comes 11th in this group. However, the spending in the US is the highest. So when you compare equals, US seems to be spending more on healthcare to get the same results. So what we also need to learn a lesson from this is we need to see why this is so. Are we wasting? Are we not cost effective? Are we doing something wrong? Now, within the healthcare sector, what is the allocation of funds? So this is something, and this is something at international and national level, and also stems from WHO. So when you look at the global spending, the maximum amount of spending is done on infectious disease and parasitic diseases, which is 37%. The non-infectious diseases is a very big club with many members, and only 26% of the budget is allocated to the non-communicable diseases, followed by unspecified. Unspecified includes a lot of trauma, reproductive health, and injuries. So government spending is more focused on infectious diseases. When you look at external funds countries, then you will also see a similar pattern where on the left side, you will see a graph where at the top is the allocation for infectious diseases, and the low bottom is non-communicable diseases. So there is maybe only 1.5 lines of spending on non-communicable diseases. When it comes to private spending, when a person is paying for themselves, the lines are a bit more. So more is spent by private people on non-communicable diseases. And when it comes to external aid, the figures become even more dismal, where most of the external aid is also going to infectious diseases, basically. So the government is spending more on infectious diseases. The external aid is more allocated to infectious diseases. Now, within this external aid, who are the people who benefit the most? And most of the funding is going to go for HIV and TB. So if you consider the countries where in the sub-Saharan Africa, so if you see the second column from your left, then you will see the green bar where most of the external spending has gone into treating of HIV and AIDS. So people who are suffering with non-communicable diseases in that area where government spending is low and they do not have out-of-pocket expenses, then the mortality of patients because of non-communicable diseases in these areas is going to be very high. So there are priorities, and there is a certain amounts of discriminatory allocation of health services, and there might be valid reasons for that. But it is time that we look at things in a bit of a different way. What is the other way where the health budget goes into? And that is primary care. Primary care takes away almost 50% of the allocation of the healthcare spending in most of the countries. Sometimes the percentage is maybe slightly different, but quite a bulk of healthcare spending goes into primary care. The third sector is immunization, which also takes care, which also sort of absorbs a lot of spending. And if you see on the right, the upper middle income countries, the immunization of the children is taken care of exclusively by the government. And if you see the bar on the left, the low income countries, then you'll see a lot of red bars. And the red bars are indicating that the spending is done by out of pocket. So even for immunization, in some low income countries, people have to spend it out of pocket, basically. So infectious diseases, immunization, primary care, HIV, tuberculosis are all priorities for healthcare spending globally, nationally, and as far as external funding is concerned. Now, where is surgery? Surgery, not just pediatric cardiac surgery.
Excuse me.
Yes.
For the sake of time, if we can conclude.
Okay, fine. Okay. Shall I just finish? So I'll just say that the scale of the surgical problem is very huge. When you don't operate surgically, we tend to lose a lot of GDP in revenue, and which is going to be to the tune of $12.3 trillion between 2015 and 2030. It is a very important statistics, because we always say we will not allocate funds to surgery because it is costly, but when you do not operate, you lose life and you lose money. There are a lot of solutions for this, and the one solution is to increase the fiscal space. And fiscal space means that the ability of the governments to allocate more funds to a particular area without destabilizing the macroeconomy. And there are a lot of things that can be done, like increasing GDP, increasing health budget, health sectors, specific taxes, efficacy, external sources, innovative financing. When you get the funds, they can be pooled, they can be mobilized, they can be channeled, they can be allocated in a very smart way. We can have various other very efficient ways, like the United Aid, where a small levy in the airlines increased the revenue for healthcare for HIV by 1 billion. Which was not even seen by the passengers who were flying the planes. When you have products like Apple and iPhones, a small percentage can be given to you, and that levies are also important. Voluntary organization need not be forgotten because they contribute to economies in trillions. So there is a study on 160 voluntary organizations which provide surgical care, and in 7 years they increased the amount of spending they did in voluntary operation was to the tune of 3.1 billion. So the contribution of voluntary organization should not be there. So if there is a will, we can increase the fiscal space, do innovative financing, and improve our surgical results. And if we really want to have the universal WHO goal of universal care for everybody by 2030, then you will have to see that surgery is also catered to. So lastly, I will say every country should decide what is the best fit model for its economic, social situation. Hybrid models might be an answer. Multiple stakeholders should come together and work together. And lastly, as a surgeon, I would say there has to be a shift in paradigm. Surgery is very costly, but not operating, not doing surgery is costlier. It costs you losses in your GDP, trillions in your economy, and in addition to the loss of life and limb. Thank you.